or as part of a functional brushing your teeth or doing things, around.
Yeah, that was I'm sorry, that was one of my thoughts, is that she just got this chair. I thought it was unrealistic before the chair, but now that standing makes it so much easier.
Yeah.
Is that unrealistic? I don't know.
Well, I think that it can be, and again, it depends on her exam and on the details, devil in the details as always. But I have adult patients who are independent in their apartments by virtue of the fact that they have a sit-to-stand chair. So in other words, they have a relatively lower sink and some low cabinets in the kitchen, and they're able to roll into the bathroom, use the sit-to-stand function, and then brush their teeth and do toilet. And then if they didn't really have that capacity, they would need a lot more help. So that's something that I'm always trying to extrapolate, not from 8 years old to 10 or 12 or 13, but also 8 years old to 25 years old. And that's the problem that you and I have, because we don't have the evidence, we don't have the information to really give us that, to help us make that decision. But if there were, if she is comfortable using the sit-to-stand chair, and we're looking at how that would impact her overall function going forward, then it might be worthwhile to consider doing something to at least partially straighten her flexion contracture around the hip and the knee, and particularly around the knee with the growth modulation surgery. Yes?
You mentioned intensity when you were talking about either exercise or PT or something like that.
Right.
Can you elaborate on that?
Yeah, so the question is, I mentioned intensity, and what do I mean by that? This is I hesitate saying it's new, it's not new, because we've all been thinking about, we think about intensity of all the treatments that we perform, but there's and what got me onto that was the work that's been done in children with congenital neuromotor problems, with how the functional MRI is affected by intensity. So abnormal MRI readings on the brain can be partially corrected, but only when the therapies applied are very intense. We're talking multiple times a week and for longer periods of time. So there's a whole movement now looking at how to develop therapies that can be applied for more time, more frequently, but have to be engaging, right? You can't get a 8-year-old who really just wants to be on the computer to be doing some form of manual therapy if they're not engaged by it. So those are all things around this. But so for the kind of like moving from the 30,000 foot, research meeting level to what real life is, it's made me think over and over again when I'm writing those prescriptions, how often should my patients be getting physical therapy? How often should they be having to perform those motor functions? How often should they be stretched? And my kind of intuitive answer now is more is better. Question?
I think you actually answered it again. Where do we go to get an exercise program for our time for ourselves who have neuromuscular problems? Because it is fairly rare. I don't think you can just show up at a physical therapist and say, maybe a program. Where would we recommend you find it?
Yeah, it's very tough. So I
Dr. Roye, can I interject? Sorry. So tomorrow afternoon, we're having a panel with a couple of physical therapists, and there'll be a discussion based on exercise selection and vigor and intensity as well. And so that might be appropriate there. If you're around this area, there are two therapists from this, well, one, I think Rachel Salazar, who's downstairs right now, who's a physical therapist at Columbia. And in fact, as highly as Clifford has talked about Dr. Roye's care, I really feel like Rachel was the best therapist they've ever had. And to me, having your child engaged, if your therapist isn't engaging your child in the session, it's not the right therapist for your child. Move on. We've had 10 or more physical therapists, and honestly, when it's just not engaging and the child's not really invigorated by the session, that it is defeating to them because they don't find purpose in the exercise, and it can be it can hurt their desire to want to participate in those kind of things. And I will relate this back to your intensity idea, because the intensity idea was something that was floated out there a long time ago to all of our community. When you think about your child doing a defensive cry, about to be poked by a needle, get defensive and scream, when their vigor and intensity is there, they can bring on muscle tone. Right? You've seen them hit their highest tone levels when the intensity is there. And so if you imagine that some training could be promoted or provoked from up here rather than at the muscular level, right? Get the brain to totally commit to turning on a muscle, then you might get more out of it. If you do that in subsequent sessions, then you'd see greater and greater follow through of those muscles. So that's the intensity, I think, piece that Roye is starting to suggest that's been explored in the literature. And it basically is trickling down from high-level athlete care. If an athlete can train at the highest level, at what point does the brain get upregulated to say, hey, this person needs more? The fact is that most people with NM are protected, they do safe exercises, and that generally feeds into a detraining, deconditioning environment for that person.
I totally agree. It's another thing, we're just starting, the Weinberg Family Cerebral Palsy Center is just starting a relationship with Berk's pediatric research division, and they're doing transcranial magnetic stimulation of the cortical surface of the brain directly related to make the brain fire muscles. And it has lots of different purposes, but one of them is related just to strengthening. It's very early work, but that's another, but it's really, it's kind of exciting to me. I've been around a long time, but to finally see that people are coming up with ways to really make therapies work. The other, we just heard a talk from Darcy Phelan, who runs the Lorview Children's Rehabilitation Center in Toronto, about using assistive devices, tablets and computers, and game playing to around therapies to encourage intensity and to encourage engagement. So there's a lot of stuff going on, but so I mention it because I want people to know about it. But in I think that you have the best ideas for just what to accomplish right now today.
Can I give one good example of something that I find engaging and therapeutic? Like Wii Sports.
Wii Sports, yeah.
Right?
Yeah.
That's one of the things he's talking about, because
Yeah.
there are tools now with Wii Fit and Wii U to interact with the screen, to get your child to do movements that adapt to their ability on the screen, and then you can raise intensity level and stretch. So you give them the feedback to say, can you hit this comfortably, can you hit this uncomfortably, and when can you take it to that next level?
Yeah, that kind of stuff really does work. And another name in that field is Andrew Gordon at Columbia, who does works with hemiplegics primarily, not MD, but has they do all kinds of game playing to increase range of motion and strength by having the patient reach, and that stuff does work.
Can I ask a quick question too? One of my questions has always been, a lot of the times when you see someone with a neuromuscular disorder, they are using compensatory gait and sort of, they modify their own levers, right, to be able to stay ambulatory. How often have you found that when you do a corrective surgery, like let's say spinal fusion, even with growing rods or not, that they might lose gait functionality?
Yeah, there's one of our, we're very careful. I'll just back up a little bit. When we're doing scoliosis surgery in patients with all kinds of neuromuscular disabilities or etiologies, it's frequent that we have to go to the pelvis. And so, because if you don't get a hold of the pelvis, then the scoliosis will progress at the peak levels of the unfused at the bottom of the spine. So when you grab the pelvis, you're denying the patient the use of lumbar motion and of the kind of sideways motion of the pelvis. So our fear is that in the marginal ambulator, when we do that, we can actually impair walking. The answer is it is a concern, but it's interesting that in our experience, we've not actually had kids lose the ability to walk. What happens is that it requires a fair amount of intensity in the rehabilitation. And in that group of kids, I always ask, we start talking well before the surgery about doing at least a month or 6 weeks of inpatient physical therapy so that they can get them walking in a pool, get them really have 3 sessions a day with a knowledgeable pediatric physical therapist to kind of get that patient back to ambulatory potential. But for the most part, we can get them back. But you're exactly correct. It's a big concern.
Yeah, I gotta see that.
Yes.
I had a question. You talked about biophosphonates. My 11-year-old son, we're kind of on a wheel now. In September and October, he got stress fractures from just walking, and we've been with Bone Health probably since he was about 3.
Yeah.
They did have him start Zometa. We did one infusion. He did have all the bad side effects. And now what we've found, we've been doing therapy the most that we can. He's lost a lot of range of motion. He's gotten tight in his hips, his knees. And like, so all of our therapists are even saying, like, we're worried, like, how far did we push him and not cause another fracture? His DEXA scans are showing, like, it's weak. And like, what do we do? Is there more than the Zometa and just trying to exercise? And how far can we push him without the fear that he's going to break another bone?
Yeah, that's a very tough question. I mean, I think that one of the things I might ask the endocrinologist is would they, so what I've done with some of my patients is in consultation with the endocrinologist, we varied the doses. So in other words, it's a kind of standard dose of Zometa. So I have one patient now which is on like 30% of the recommended dose, and that got her past the complication, the medical complication that she was having with the medication. The other thing that I've done with another child is that we are doing a reduced dose of Zometa, and we just are planning a hospitalization around it. So in other words, instead of doing it as ordinarily would be done as an outpatient, we actually have hospitalization, and when you're ready with the appropriate treatment for the medical complications. There's and then there are other medications too. There are other infusion bisphosphonates out there that can be tried, and I'm not the right person to give you that advice. But that's a little bit of kind of generic advice I can give you from my own experience.
Is physical therapy, can we?
Yeah, it's interesting. Yeah, it's like it's right. We're in between a rock and a hard place, right? Because if therapist doesn't want to be responsible for hurting Busan on one hand, but then of course we're hurting him if we're not treating him. So I think that and And I think that some of the symptoms that you're describing are actually from bone pain. It's because I think that my patients with NM and other myopathies, when they get this osteopenia, that they're like my patients with OI, with osteogenesis imperfecta, who have kind of constant microfractures, and they just have bone pain that is very often is treated successfully with the dysphosphate. You know, so that's kind of like the baseline. I mean, I would, you know, this is like mom and apple pie. But I mean, I would encourage the therapists to be as aggressive as they can stand, you know, and to keep treating and remembering that without weight bearing, without motion, the bone disease gets worse.
Maybe last question.
We're running behind.
You're probably hoping I wasn't going to ask a question.
Oh, yeah.
You spoke about pelvic stability with the spinal surgery. It's something I haven't heard of before. Is that something that's quite new, or is that something you've been doing for quite some time? I guess I ask that because Xander's been a wait-and-see approach for a very long time because of his respiratory status. The concept of growing rods was not applicable for him because there was nowhere to fix them, like there was no anchor point. So the idea of the hips is actually something that I've never come across.
Yeah, it's actually pretty standard. We've been doing it for a long time. Technically, I have to say we're a lot better at it now than we were, 10 or 15 years ago. So even when we're doing, a patient that resembles your son, on our service would be halo traction for 2, 3, 4 weeks, followed by instrumentation, pelvis to probably upper spine instead of ribs, but that would be I'm totally guessing, just looking at it. But there's it would always be pelvis, and so that leaves the entire lumbar spine untouched. So as we go forward through growth, lumbar spine and the lower thoracic spine are responsible for more vertical growth than is the upper thoracic spine. So the more we can leave that lumbar spine alone, the better we like it, because it gives us a longer trunk height, because we figure most of our patients, their functional height is going to be their sitting height. So we want them to have the longest trunk as possible. That technique of grabbing the pelvis, even when we're in the growing rod situation, is our kind of, I would argue,